The point is that these organizations for delivering care are on a track to become accountable, not just for the volume and intensity of services that they provide, but for improving quality of care and health while reducing costs for their patients and the overall healthcare system. At the core of this concept is not accountability for its own sake, but providing an effective means for supporting providers in their best efforts to improve quality of care and reduce costs. You can think of it as a reward. I think of it as really support. As we heard about earlier today, a lot of steps around care coordination, around getting it right for a particular patient, around putting the person at the center of care. A lot of those steps just aren't reimbursed in traditional healthcare systems, and we've seen, especially with rising budget pressures, the difficulty of making piecemeal changes in those systems to expand fee-for-service or something like that don't seem to be getting us there. So accountable care takes another approach, and it starts with this concept of shared savings. Because providers that are now tracking the overall results for their patients get a share of the savings when they reduce overall cost trends while improving quality. That's what drives the additional support for these reforms in care delivery. And that notion of shared savings is what Don Berwick this morning called a core model for how CMS is thinking about and moving forward on implementing the ACO program. These steps are intended to make improvements in care more sustainable in a way that current reimbursement systems do not. Providers have many ideas about how to improve care, how to get costs down, remove unnecessary costs, but often they're swimming against the financial tide, and it's harder to make ends meet in their practice when they're taking this extra time or taking this effort to reform care delivery or make investments in changing their practice. And so that's what the accountable care payment reform side is intended to address. The most basic version of this is the so-called one-sided shared savings model, which may operate within a fee-for-service environment, if that's sort of the baseline on which this new payment stream or new payment track is being added. It means no new risk for losses if spending continues to go up without improvements in trends. It's just an opportunity if reductions in spending trends occur, along with the kinds of measured improvements in care that we've already heard about today. It's an opportunity for new resources. Now, many people view this as a relatively straightforward way of starting to implement ACOs. In fact, in some of our previous papers, we've described a stepwise approach to ACOs starting here, starting where many organizations that are trying to improve care and lower costs are likely to be in 2012, where they have limited availability of IT infrastructure and support for these kinds of care improvement efforts, and it can be a first step, an incremental way of moving into a different way of being paid. You know, think of it as having two tracks for payment starting to operate at the same time. So we're still barreling down the traditional payment track with fee-for-service payments or whatever PPO arrangements are already in place. But in addition to that, there's a separate track set up where providers are now starting to be explicitly paid based on tracking and improving overall results for patients, patient experience, and overall cost trends. And the shared savings approach just adds that onto the existing payment track.